for a webinar by Professor Reza Malekzadeh of Tehran University. He is a distinguished professor in international medicine, and he's the director of Digestive Disease Research Institute in Tehran University of Medical Sciences. To start off, I would invite His Excellency, Professor Dr. Muhammad Iqbal Chaudhry, for his welcome address and to welcome the distinguished speaker. Over to you, sir.
Bismillahirrahmanirrahim. Assalamu alaikum. Good morning and good afternoon, ladies and gentlemen. Thank you very much, Professor Dr. Reza, for joining this distinguished scholar series. Comstech, as we all know, it is Ministerial Standing Committee for Science and Technology, comprised of 57 member states of Organization of Islamic Conference. And comstech is heavily engaged in many projects, which include capacity building in the field of health, environment, and engineering. Health is certainly an extremely important component of development endeavor. This pandemic has shown us that health should receive the highest priority, being one important element on which human well-being and survival based. So today, health, nutrition, clean air environments are among the top priorities of humanity. This pandemic has shown us that we need to invest both in capacity building as well as in institutional development. We live in mainly developing part of the world. Several of the OIC member states are least developed countries, and they suffer from triple disease burden. We have this tremendous disease burden of genetic disorders, and then we have infections of all kinds, from tropical diseases to multi-drug resistance infections. On top of it, we also have metabolic disorders called lifestyle diseases. And these diseases are affecting many of us. The disease burden in developing world is unfortunately beyond the capacity of these nations to handle diseases at that magnitude. Therefore, it is extremely important that all countries, regardless of their size, big or small, develop their own capacity to take care of their people in the field of healthcare. Iran has done remarkably well. Iran is a sufficient self-reliant country in terms of healthcare. They're producing their own vaccines, pharmaceutical, and they have a very high quality healthcare system. On top of it, this healthcare system is supported by a very comprehensive healthcare research system, which include lots of very high quality institutions all around Iran. We have with us a very distinguished speaker today, a clinician as well as a researcher, Professor Dr. Reza Malekzadeh. He is a gastroenterologist by profession, and he is associated with a very famous university, which is University of Tehran. Professor Malekzadeh is a distinguished professor. He's an excellent researcher. He's the director of the Digestive Disease Research Institute at Tehran University of Medical Sciences in Iran. And he would be speaking today on a very important topic, and that is how to handle the whole consortium of metabolic diseases by single pill. So by appropriate therapy. So he's talking about polypill and lifestyle diseases. There's so many of these lifestyle diseases which are affecting people all around the world. His primary focus is on prevention of cardiovascular diseases, and we would looking forward to have a very exciting presentation from Professor Dr. Reza Malekzadeh. So Professor Reza, over to you, sir.
Internet is unstable.
Professor Reza, over to you now.
Yes. Very much for this introduction. Bismillah ar-Rahman. First of all, I would like to present the reason why, as a gastroenterologist, become interested in preventive cardiology. This is the Golestan cohort study. Esophageal cancer in Iran was in 1997 be the highest incidence world in a part of Iran, North Iran, which were past before revolution were linked to poverty, low in fruit and vegetable. This done by International Agency for Research and School of Public Health at Tehran University of Medical Science. In this area in northeastern Iran, they have reported one of the highest rate of cancer, the 90 per ASR. This was one of the reasons why I have started to find the reason for this very high incidence of cancer in northeastern Iran, in collaboration with the National Cancer Institute at America and also International Agency on Research in Cancer in Lyon related to WHO. And this is our center, Digestive Disease Research Center. We started a project, we call it Gemini, gastroesophageal malignancy in northern Iran. And this patient PI, Dr. Paolo Boffetta from WHO and Dr. Sandy Dowsey from NCI. We make a team of very interested researchers, some of them PhD students and other young researchers to study this, and then established collaboration around the globe with many major research institutes, which most of them were very interested on understanding the reason for this very high the meeting we're very interested in understanding the reason for very high incidence of cancer in northern Iran. And we, of course, had collaboration with many other universities and scientists across the globe and made a very big team of researchers. And this is the Gombat city in Golestan, which was the center of this high incidence area of cancer. We have received a very strong support from Professor Nick Day from Cambridge and also Cancer Research UK, and also Dr. Sir Bruce Ponder from Cambridge, who visited our field, and they helped us to obtain grant from Cancer Research UK. The Gemini consists of several projects, including cancer registry, ecologic study, pilot study, case control study, and also the finally Golestan cohort study, and also interventional trial to prevent the chronic disease. And this was the plan which we were able to succeed very successfully and establish all this step and finally establish the Golestan cohort. And now we are also doing the early detection and screening. And we have established a clinic, we call it ATRA clinic, in the Gombat city in Golestan, northeastern Iran. And for the first 2 years, we just provided care for the people to make trust our team and the people in the area. And this was free service to all people who had gastrointestinal disease and were suspected to cancer, providing free endoscopy and pathology and treatment. And this make the possibility to do this Golestan cohort study, which was a observational prospective study, which we planned it for 20 years actually. And the Golestan cohort study, we first did a pilot study in 2003 with collaboration of NCI, IARC, and other universities. And then when we had succeeded with our pilot study, we started the actual study and enrolled 50,000 subjects from Golestan province in 336 village and Gombat city in a questionnaire of both general question and dietary, about 300 questions asking from people, and also the biological sample and a biobank of blood, urine, and hair and nail. These 50,045 participants, more than 40 years, from 330 village and the Gombat city. The mean age was 52, 80% rural, 58% women, 70% had no formal education, and 80% were of Turkmen ethnicity. This type of cancer were especially common in Turkmen. And therefore, this is the area of study, and also this is the people who were mainly enrolled. And this was the team with in the Gombat city and biobank, which we also divided. 50% of them we sent at IARC in order to make sure that our sample not being lost due to events. This is a detailed dietary questionnaire. Is Dr. K.K. Cheng, who came from Cancer Research UK to just visit our site. And we did a recruitment up. We had the 60 day of follow-up with 99% success rate on that area. And for cancer, we established many papers, and this is one of the last one on gastroenterology, which we were able to clearly show that 76% of the etiology of the cancer of esophagus were low fruit intake, indoor air pollution, hot tea, tooth loss, low vegetable, opioid use, and also unpiped water drinking. And
Professor Reza, we can't hear you anymore.
Sorry for the interruption. We have some issue with the connection of our resource person. He'll just join again shortly. So we'll resume the session again.
we finally were able to answer the question about esophageal cancer. That what this cohort was the fact that about 50% of people in Golestan cohort are actually dying of cardiovascular disease and stroke. 50% are hypertensive. 70% had at least one risk factor, cardiovascular risk factor. And 50% had 2 risk factor, 20% has 3 risk factor. And 35% of this 50,000 population had actually fatty liver, non-alcoholic fatty liver disease. And when looking at the etiology of death in this population, we found that about 50% of people, 41% of people are dying of cardiovascular disease. And esophageal cancer is actually not a very important etiology of death. And about 63% of these Golestan cohort participants were died prematurely before age of 70. And the main cause of death was ischemic heart disease, about 33%, stroke, and also other, and esophageal cancer was only the etiology of less than 5% of deaths. Looking at the Tehran coronary artery bypass graft data, we also found that about 50% of the Iranian people, the Iranian people who undergo coronary artery bypass graft surgery, they do it 10 years earlier than European country. And the only country which were similar to us were Armenia, which we were also very similar, had a similar lifestyle. Therefore, we came to the conclusion that major cause of death in is cardiovascular disease. We are looking for all things, and that cancer. For this reason, how can we prevent disease? And at this time, concept of polypill evolved and law in a journal in BMJ. A single pill could reduce the risk of ischemic heart disease by 88% and stroke by 80%. This came to surprise for many scientists, but they raised the possibility of once daily using the drug to treat all patients with cardiovascular disease, as those 55-year-old and older. And this strategy, as a matter of fact, will reduce the need for diagnostic and therapeutic, which has a huge cost. Therefore, we decided to think about this. And the concept is very, very interesting. You need not to go to doctor every 3 months to get your blood pressure and serum lipid level measured. Do not be bothered with all that. You just get your Polypill every night. It's extremely simple and very cheap. Instead of many pills, you can take only a single pill. Dr. KK Cheng, who came to visit us from Cancer Research UK, where when I talked with him, he encouraged us to do this study in our setting and we first did a similar study to analysis like what Wild did in the BMJ, and just calculate the amount of efficacy of polypill if we use it in Iran in Golestan cohort. Our colleague, Dr. Gudars Danai, who were working in Harvard University, also joined us. And we did this study. This is just a theoretical study. And we realized that polypill could prevent 41,200 cardiovascular disease each year in Iran. This just was the estimate based on the data. As a matter of fact, this was a conservative estimate in this meta-analysis, and we could have prevented 28,500 ischemic heart, 1,700 stroke in 2006 when we did this study. This finding just make us more interested in doing this poly-Iran study in Golestan cohort. And I thought that we can do more help to our people doing this study rather than just going for this cancer. This is an example of a study which we established by collaboration. We call it Gemini. This provides evidence for the feasibility of a large-scale health research country and serve as a successful model, not only for health research in Iran, but also for similar research studies in the region. I now go to the main lecture, which is the polypill. This was just an introduction, and the reason why we have choose to بازم این اومد میگه که اسکرین نمیدونم فلان چی اسکرین شیرینگ استاپ آره درست اوکی حالا باز I'm going to now share another please help me to share my screen again. And this is the main lecture that I am going to therefore, now I'm going to talk about this. I just want first to mention why we focused on this. What was the reason for it? This is the polypill and lifestyle, the main lecture. I don't have any conflict of interest. There is to first talk about CVD burden and then the clinical strategies, polypill idea, the setting and design of the poly-Iran trial, the finding and the meta-analysis. The cardiovascular disease is actually the biggest epidemic in the world that the world has ever known. This affecting 1 in 3 individuals in the world, in showing worldwide shortage of cardiologists and specialists to treat cardiovascular disease. And this actually need a new treatment paradigm. It kills 80 million each year in the world. And it's almost 30% of all deaths in the world globally. About 40 million people have non-fatal CVD. And 423 people at the world are suffering, and this is the prevalence of it. This is actually the biggest epidemic of the world has ever known, and we need to do something for this. If you look at this cardiovascular disease, ischemic heart disease accounts for almost 50% of it, and stroke, both ischemic and hemorrhage together is something about 30%. And the rest are other cardiovascular disease. And it involves all the world, and especially the developing country, Islamic country around them. When it's increasing, if you look at the rate from 1990 to 2019, as you can see, the rate is increasing. And the cost is huge. This is the cost in America. And this is the cost in European country, which is huge. And most of the developing country actually cannot provide this cost. And if we go according to what we are doing now, we will not be able to reach this SDG goal of reducing 30% premature deaths. And we need to have a urgent need to focus on implementing existing cost-effective policies and intervention to prevent cardiovascular disease. What causes the cardiovascular disease? There have been huge studies on risk factors. And as a matter of fact, many of the risk factors are modifiable. This needs to have a plan for it. Two of the major ones is high systolic blood pressure, high LDL cholesterol, and others are lifestyle, like dietary, high fasting plasma glucose, tobacco, high BMI. And these are the risk factor, looking at them as 1990 and recently 2090, you see that again, high systolic blood pressure, dietary, and high LDL cholesterol are at the top of these risk factors. And 60% of all deaths about cardiovascular disease occur in developing countries, among them Islamic countries. And we really can do something for this very deadly disease, which produce a lot of disability. As a matter of fact, many studies have shown that poor people are at greater risk of heart attack and stroke. And especially women are more suffering. About 8.6 million deaths in women each year occur due to the cardiovascular disease. What are the challenges? Why we are not doing it? The major challenge is that it is quite difficult for people to change their lifestyle, stop smoking, increase physical activity, decrease weight, having a better, healthier food, eating healthier food. These are the main challenge. It's quite difficult for people to do this. In Iran, about 41% of deaths are from cardiovascular disease, only 20% from cancer. And as a matter of fact, looking at the total number of cardiovascular disease in Iran in year 2017, 142,000 deaths, which is 37% of all deaths in Iran are from cardiovascular disease. How many of them are premature, less than 17 years, and some of them even less than 50 years? 47,000 deaths from cardiovascular disease are premature, and people are dying early in life or became disabled during the rest of life. I have already shown this to you, that in Iran, Iranian people develop ischemic heart disease at least 10 years earlier than other European countries. Therefore, this is a major issue in our country. And we should really target this modifiable risk factor, invest in existing cost-effective public health program, promote healthy aging across the lifespan, reduce disability and premature deaths due to cardiovascular disease. And but what we are doing at present time is just to diagnose symptomatic cardiovascular disease, to treat patients with cardiovascular disease, do stenting, do surgery. These are expensive, not available for all low and middle income countries, and it produces a major suffering and disability. Therefore, this is a study, we call it the pure prospective urban epidemiologic study. This has shown that people who once develop myocardial infarction and we gave them medication, less than 50% of them continue their medication, and they are non-compliant to their medication. Therefore, there have been many requests and papers by scientists across the globe that we really should do something to prevent cardiovascular disease. Even they mentioned it, the Alma Ata rebirth and revision for cardiovascular disease prevention, as we did it for infectious disease in the past. Therefore, we need to think of clinical strategies to reduce CVD burden. We may just treat the risk factor when incidentally found. This is what we usually do at present time, or check everyone for risk factor at regular interval. This is the recommendation, but it's expensive, and maybe some high income country doing it, even they don't do this. A better strategy is probably to stratify the population based on their risk, age, clinical laboratory CVD risk, heart calcium risk score, and also provide intervention based on risk score. This is what the law and the Wald and Law suggested in their paper in BMJ. And as I mentioned to you, they claim that they can reduce 80% of cardiovascular disease by just Polypill, we did a similar study in Iran. We also found that if using Polypill, we can prevent 41,200 cardiovascular deaths each year in Iran. And these were the motivation for us to think of the Polypill concept. And this is the fact that screening everyone at age 35 to 40 years for risk factor and fixed interval, and the nationwide, low-cost, early, and sustainable intervention to prevent cardiovascular disease. Instead of these many pills, we use only single pill. When we give many pills to a person, even for those who already had a myocardial infarction, more than 50% of them, they just don't take the medication, or they take it irregularly, or not all of them. This is the study that was published in 2013. Therefore, the reason for one pill is that it is difficult for people to take many pills. Risk factors are usually asymptomatic. For people, it's hard to remember multiple medication. It can be expensive. They need to go to the doctor to obtain, and they need to pay for this several drugs, and many of them cannot offer it. And as I mentioned, if we just give one pill, it is very easy, and we can, it is efficient and cheap and easy to apply. And we are giving study, it was given to the people by Behbars. They are auxiliary health worker in Iran Health Network. It's practical. Taking a single pill, it is people had very much better compliance, and it's cost effective. Of course, there are many people who think about disadvantage of giving one pill to for all risk factors, because there is lower ability to tailor the drug, and hence overtreatment, potential drug-drug interaction, medicalization of the primary prevention, and also bioavailability. These were the question. Looking at the literature about Polypill before we start our Poly-Iran trial, or the conclusion, the literature and evidence show that the Polypill increased the adherence. It reduced blood pressure and LDL cholesterol. Side effect, improve quality of life, most likely to be cost effective, and it already have been accepted for secondary prevention. But there were no long-term study to assess efficacy to reduce major cardiovascular event, particularly in primary prevention setting. This is International Journal of Cardiology, which has mentioned prevention. Therefore, probably we better to go to Golestan cohort study and do this Polypill lifestyle project. We were able to make the Polypill in Iran. Our Alborz Daru company were able to prepare Polypill and do the studies and show that this Polypill has a very good pharmacodynamic and serum level. The Polypill we made contain of aspirin, 1 milligram, atorvastatin, 20 milligram, valsartan, or enalapril, 5 milligram, because some people develop cough with enalapril. Therefore, we can use the Polypill 2, which contain valsartan. And also hydrochlorothiazide, 12 milligram. And this is given as a daily dose in the evening after dinner. One concern was the aspirin, because many people were hesitant about aspirin. They think that the aspirin would increase GI bleeding, and therefore we discussed this. The consensus was that generally it worth using aspirin if the 10-year risk of MI is over 5 to 10%. In Iran, it was about 17%. Therefore, it was we were satisfied that we really should add aspirin to our Polypill. Another major issue was whether we should use Polypill for primary prevention or secondary prevention. We decided to do it for both primary and secondary. one reason was that 80% of cardiovascular events are vascular disease. And if we really want to make an impact, we should do primary prevention. And therefore, this polypill or fixed dose combination, in our study, we decided to do it for both primary and secondary prevention. For secondary prevention, there were already adequate evidence, but for primary prevention, we need to make evidence in our study for future. For the risk score, we also decided to use age alone rather than CVD risk score, because age alone can be used to treat a vast majority of patients. If you go and look at this complicated risk score system like Framingham, or use just age in men and women, you end up treating almost the same people. There are some differences, but they are not that many. And the simplicity of the concept is we used age only in this trial. We made our team, the team of from Tehran University of Medical Science, from Golestan University of Medical Science, and also a colleague, Marshall and KK Cheng, and they also help us in pilot study. We enrolled 475 subjects and randomized double-blind placebo-controlled trial. During the pilot phase, we used the double-blind placebo-controlled trial, 12 months. Aspirin, the same polypill we used. This polypill had only 2.5 milligram enalapril, which we in the main phase increased it to 5. The aim was tolerability, compliance, side effect, effectiveness, and feasibility, whether we really can do this study in the Golestan setting. We, as a matter of fact, did it very well, and we published it about 2 years as in Clinical Practice Journal, as you can see here. And the conclusion from pilot study was the study is feasible and the polypill is effective. We need a better design to cancel the placebo. It was quite difficult for people when we told them that you may take tablet or placebo. This was one negative point for doing this study. We need 2 types of polypill, one without enalapril. And we decided to use, because everybody has a mobile in that area, use a message, SMS, text messages to increase adherence and for the lifestyle. These were the conclusion. And then we started to design the main study, about a year of weekly meeting and many telephone conferences with national and international consultants, and try to design a very good study for the main phase study. And we call it the Poly-Iran trial, designed as a cluster randomized pragmatic trial nested in Golestan cohort study. Inclusion criteria was all people older than 50 who are included in the Golestan cohort study, 31,000, especially the rural participant. Exclusion criteria were contraindication for the use of each component of polypill and medical problem which prevent use of polypill. We choose the pragmatic clinical trial, and this doesn't have placebo group. And this is actually a much better trial for doing large, big studies. And it's more general, the result is more generalizable to the population. Also, this is the so-called the cohort multiple randomized control trial. A cohort study are very good to nest the clinical trial within the cohort. And this is what we did actually in this trial. There are 7 key factors that make this trial, pragmatic trial, much better than the conventional double-blind placebo control trial, which I have mentioned it in these 2 slides. The trial may be valid and useful in the healthcare setting in which it was conducted. This we call it internal validity, but have limited applicability or generalizability, which we call it external validity, in real world clinical practice. The pragmatic trial is has more external validity than placebo-controlled trial. And this were the reason why we choose this, and this is the design of our study. Just a randomized study in order, of course, we adjusted for clustering during our analysis. This is the main design. I would make it simpler here for you to look at it. The Golestan cohort study with 50,000, more than 40 years. We choose about 28,660, more than 50 in rural, which was in 336 villages around the Golestan. And then in northeastern Golestan. Then we did a random selection from this population of about 6,838 subjects who were 50-year-old, and then made them two groups. One group is for Polypill only, for Polypill, one tablet, care. And the control were lifestyle and minimal care. We provided lifestyle and minimal care also for the control group, and then we compare it with usual group, where the rest of the people that were in, we choose 5,000 of these as usual care, which we didn't, we just let them live in their usual life and provide and receive the care which is for other people in the society. Therefore, we had the Polypill group, we had the minimal care group, and we have the usual care group. The Polypill care group is 3,421. These received the Polypill and lifestyle and minimal care. The minimal care group received only lifestyle and the minimal care. And of course, they were non-blinded control. We call it pragmatic design. And the usual care was 4,000 people in Golestan cohort over 50 only received the usual care which other people in the area received. The control group received minimal care, Polypill group received minimal care plus Polypill tablet. The definition of minimal care is a package of non-pharmacological intervention, including blood pressure assessment, as well as educational face-to-face training by 300 auxiliary behbars were involved in the study to talk with the people and to train them for lifestyle. And Polypill tablet, a combination of, as you can show you, aspirin and two blood pressure lowering device, and also atorvastatin. And our endpoint was cardiovascular mortality, non-fatal cardiovascular event, and hospitalization, admission to, and coronary artery bypass grafting. Three of my young colleagues were appointed as the field officer. These three were the first author in that paper: Dr. Roshandel, Dr. Pouschi, and Dr. Khosh. We used both for primary and secondary. The study was started in on those villages, 330 villages, and with the help of 300 behbars. For every 1,000 people in Iran, we have 2 behbars. And these behbars were in the area, and they were very helpful to help us for both lifestyle and also for pill count, for people who were on the trial arm. These, we call them behbars or auxiliary health workers. And these are the people were invited to come to the villages. Our team with a car go to a different village, to health house or health centers, and invited the people to come, and the enrollment take place. We usually on day 0 ask the general question, changing the age of the participant, and also physician interview, filling the Polypill questionnaire, and the behbars measured blood pressure both in sitting and also in standing position for all of the participants. And also we completed the questionnaire about inclusion and exclusion criteria, and we provided this pamphlet for lifestyle and talked about this face-to-face with both with all participants And this is the pamphlet which actually described the about the cessation of cigarette smoking, stopping opium use, and also checking blood pressure and having ideal weight, taking healthy food. And then we also draw blood from each participant. The participants were very kind to provide us again blood both before and after the stopping, finishing of the trial. And in order to make sure that the people can tolerate the polypill, on those groups who were in treatment or on polypill arm, we gave them 1 tablet of polypill to take and come to us on the next day to measure their blood pressure and to ask whether they have developed dizziness or any major problem, to make sure polypill. And if somebody cannot take polypill, then we exclude them. Therefore, and this is the Golestan cohort lab, which were on the same area, and we did check all the laboratory tests for the people. And as a matter of fact, we provided the result of lab to all participants. This was an incentive for people to come to join our trial. This was a complete CBC and also chemistry, liver function test, kidney function test, and urinalysis. And then we entered the lab result in the questionnaire, and if enrolled the participant is advised to visit the doctor, and we all control group, we ask them that if you have a problem, you can go to your physician even, and if they have the found to be had blood pressure, we didn't give them drug, but we asked them to go to their primary physician and be treated for their hypertension, in spite of the fact that they were in a control group. And then if participant is intervention group, we gave polypill for 3 months in these bags, and we also published the design paper, which is in, can read this in more detail. This is in European Journal of Preventive Cardiology, year 2014. There were some concern about the limitation of polypill. Physician would be reluctant to ignore cardiovascular scoring system in favor of one size fit for all to healthcare. Physicians, especially cardiologists, have been trained to treat rather than to prevent disease. And this is very interesting that we train cardiologists and they go to their clinic and they wait since a person developed myocardial infarction or stroke and then treat him. This is something that I think we should change it in our even medical school. And of course, some mentioned that you are doing medicalization of this society, decreasing the motivation to healthier lifestyle. If somebody take the pill, he may feel not necessary to do exercise, not necessary. These are also the concern about polypill. And therefore, we, in our control group, we use the lifestyle and also provided the minimal care in order to make sure that we can do support those people also. The Poly-Iran enrollment was started. The enrollment phase of Poly-Iran takes 2 years and began in February 2011 and completed in April 2013. Phase began on Thursday 2011 and has been continued non-stop till the end of the study. The protocol was to follow intervention arm village at month 1, 2, 3, 6, and then every 6 months after that, and to follow control and to follow control arm village at months 3, 6, and then every 6 months after that. The follow-up phase was finished on May 30, 2018. And this was the polypill arm and minimal care arm. Their baseline data was almost similar to each other with minimal change. Poly-Iran result, main finding, during 60 months follow-up, the number of cardiovascular disease event was 301 in control group and 202 in polypill group. And these results suggest that our intervention, polypill intervention, could decrease 34% the risk of cardiovascular disease. And this was exactly what SDG suggests that we should do for future. And looking at the hazard ratio and also adjusted hazard ratio, because we did adjustment for clustering effect. You can see here the hazard ratio, and this is the curve, which, as you can see, the people who were taking a polypill, they develop less, about 34% overall, the 34% less major cardiovascular event, comparing the three group. This is the polypill, and this is also the minimal care group, and this is the usual care group. There was not much difference between usual care and lifestyle. This is simply because most of people in our cohort were conscious about their health, and they probably also, to some degree, they were also doing their lifestyle. Therefore, but the polypill was were definitely separated from those two. The result of the Polypill Iran study suggests that the effect of polypill was related to the duration of the polypill use. During months 20 to 39 follow-up, the risk of CVD event in polypill group reduced by 32%. But for those who use polypill for 40 to 60 months, the risk decreased to 53%. And this means that when you continue using it, 50%. And this is the adherence. As I told you, the adherence for multiple pill was less than 50%. But the adherence for polypill was 71%. And the main decline was on the first year. After the first year, those who had some side effect, the polypill, the adherence remained constant. Therefore, the adherence is actually very well. Therefore, the result of Poly-Iran suggests that the effect of polypill was related to the level of adherence to the polypill tablet. The participant with high adherence to polypill taking more than 70% of tablet during 60 months, there was 57% decrease in the risk. Therefore, those who take medication regularly, at least 70%, this risk of cardiovascular event decreased by 57%. The adverse event, a very interesting finding, was that overall the frequency of adverse events were comparable, and there was no significant difference between the two groups. Intracranial hemorrhage, peptic ulcer, upper GI bleeding, which were of main concern for aspirin and polypill content, actually was not different between the two groups, the polypill group and the control group. And some side effects as we continue the polypill decreased. And many people who had headache, for example, they with the polypill, their headache also improved. And later on, we understand that, for example, atorvastatin is effective for migraine headache also, and there have been trials of that. Therefore, these were the side effect which decrease as the times goes on. The paper was published in Lancet, the Lancet Journal 2019, which is open with its supplementary files, which you can go and read it in detail. And there was also a commentary and editorial on this paper on the same issue. And it's very interesting that this paper, although was published in the middle of year 2019, was among the, there was also a press release with it. It was among the highly cited and highly downloaded paper of that year of the among all Lancet paper. And it was a top download this week. I have received many messages that this paper was being read by and downloaded by many people. The result of this study was that we were able to prove that polypill is a good for people, and it goes in the Iranian pharmaceutical committee. It was approved, and it is now available in Iranian pharmacy. and the people can obtain it and take it if they want to do it, or the doctors can also prescribe it. Now, looking at other studies of polypill which published, which are a lot of study published, as you can see in this list, we look at all of these and try to find those long-term randomized control trial, more than 1,000 participants, and more than 2 years of follow-up. And there were many of these type of, several of them use 3 of these studies, TIPS 3, HOPES 3, which were from Dr. Salim Youssef group, and also Poly-Iran study. These 3 studies are the 3 studies that we look at them recently with the help of Dr. Youssef group as a meta-analysis. And the overall, we looked at 18,000 people on polypill with these TIPS, HOP3, and Poly-Iran study. Poly-Iran was only in Iran, but other studies were in many countries together. You can see the LDL cholesterol, systolic blood pressure decrease. Again, we can find those decline in the people who more than 34% decline in major cardiovascular event in polypill group, as you can see here, comparing to the control. This is the result of this. And also, again, you can see that the p-value were significant, and hazard ratio here. Again, this proves that this is effective. And a very interesting thing, we look at the polypill with aspirin and without aspirin. This is the polypill with aspirin, without aspirin. You can see the hazard ratio. And this is the polypill with aspirin. And the polypill with aspirin were more effective for all endpoints than polypill without aspirin. Therefore, the concept that aspirin is not effective for primary prevention is not actually true. And our study and our meta-analysis showed that we can use aspirin and this is very interesting. This is the aspirin, the green band, and this is without aspirin. And as you can see, aspirin decrease both cardiovascular, MI, stroke, CV death, and revascularization. Therefore, aspirin should be part of a polypill for cardiovascular prevention. The adverse events were non-significant actually, except for muscle pain and dizziness. The other side effects were very minimal, and muscle pain were also always transient, and when they continued on polypill, due to a statin, the muscle pain decreased. Most of the patients in our study could actually tolerate this, and the symptom disappeared. And the other major side effects were also non-significant between the 2 groups. Therefore, the conclusion is that fixed dose combination is a very good choice for primary prevention. Despite modest difference in blood pressure and cholesterol, but this polypill can decrease cardiovascular event by 38%, MI by 48%, stroke by 42%, and cardiovascular death by 35%. And if you add aspirin to polypill, actually it would improve it. It decreases CVD from 38 to 48%, decrease MI from 48 to 53%, and stroke from 42 to 51%. And CVD deaths from 35 to 49%. When benefit is consistent and different metabolic risk factor level, benefit appear to be larger in older people. It's very interesting that the age showed this very well, and well tolerated and safe. Between the public implication, if we use polypill in the whole globe, we can avoid between 5 and 10 million deaths each year. If we apply polypill in assist in reaching UN, and we can actually reach to the SDG goal to reduce premature deaths by 1/3 in 2030. Therefore, the fixed dose combination or polypill reduce LDL cholesterol, blood pressure to greater extent, likely to have even larger benefit. Older people appear to derive a greater benefit. Therefore, age could be an important clinical factor to guide us. And of course, many people who are focused on precision medicine criticize that you are using one pill for everybody. This is not precision medicine. We are following precision medicine. But polypill can even be used for precision medicine because there is not only one polypill. We can make different type of polypill, different dosage, different combination, and that's actually use it in different people. The people you find genetically more on those group. Therefore, precision medicine with polypill is possible. Polypill can have a diversity of component, including antiplatelet, lower blood pressure, lipid, fasting plasma sugar. Polypill can consist of diverse component plus different type of polypill for diverse target, but this make life simpler for our people and make the cost much lower and make it more feasible to do it. To our cardiologist, that pen is better than catheter. Giving a statin to those patients with liver risk factor may increase their lifespan more than any other therapy we offer. Writing this prescription could produce longevity with far less risk than stenting the coronavirus or liver transplantation. For liver patient with cardiac risk factor, the pen is better than the knife or the, and of course, we again say to our cardiology colleague, use your common sense, wisdom, and your pen more frequent. Then talk with your patient before using your catheter, and your courage for a splendid art of endovascular. Of course, need your endovascular surgery. We need your stent when we need it. But we can do it at their age when there is no way to do it. We, of course, need your courage and art of endovascular to save our life. Our experience also was very good because we experienced a very good scientific collaboration. It's a continuous line of human relationship and tradition since the past, like it brings culture and peoples. It brings tolerance and understanding. It delivers compassion. And we really need to do more collaboration, especially among scientists in Islamic country and also in the rest of the world, as we did in this cohort study and this trial. And this is Damavan, the tallest mountain in Iran. And thank you very much for your attention. I am ready to answer the question.
Shall we take questions now, Professor Reza?
Yes, of course. Please, I am ready to answer questions.
What we'll do is all the participants who have questions, please write your question in the chat box and then Professor Reza will answer it accordingly. Please write your questions in the chat box. Thank you.
چند نفر بودن میتونی چک کنی؟ خارج بودن. چت باکس اون کو بیارش سوالی هست. چت باکس بیار چت باکس. Did the polypill contain the different active ingredients separately by and did the polypill contain the different active ingredients separated by any film? No, the polypill was just single tablet, and we had the aspirin covered aspirin, but the other component was just not separated from each other. All of them was a single pill, as I shown it to you. Thank you very much for informative presentation. Does the polypill is variable with age? No, the polypill is since we choose everybody more than 50, and therefore we give a polypill to everybody with any age. Thank you, Dr. Malekzadeh, for interesting talk. Please write your question. Do you have Yes, we do have a pharmacokinetic detailed profile of polypill before we use polypill. And we make sure that when we gave all pill in single tablet, the blood level is similar to people who are taking it separately. This was done early in the study before we start during pilot stage. Any other question? I cannot see any more new questions.
There is one question from Aksa Hashmi. Were
Yeah.
there any adverse events related to the GIT?
Event related to what?
GIT.
What do you mean by GIT? Were there any event? GI disease, GI bleeding? I don't know what you mean by GIT.
Gastrointestinal tract.
As I told you, the incidence of peptic ulcer and incidence of GI bleeding were similar between polypill and minimal care. And this has been shown both in our study and also in other studies with aspirin, which we did it in meta-analysis. Yes, you see, the main reason was that we have shown that by polypill the adherence improves, and we have shown that by polypill the adherence almost doubled, and the people would benefit from it even during the primary. Our study was mainly focused on primary prevention. And we have shown for the first time that we can use polypill for primary prevention, which include also aspirin. آره یعنی میگه که ولی خب این فرمول یکی باعث میشه آدم راحت بخوره توجه به این نکرد. Okay, any more questions or comments? It's really very good study. I would like to invite you for such a Nice talk at my university as well as in future. Please start your email ID, Dr. Yes, I would ask Dr. Ahmad to send my email to all of the colleagues, and I would write my ID, my email here. I would be pleased to be in contact with you, and something that I am very interested is to ask you colleagues to join together to do this study in several Islamic countries, and I think provide evidence for our policymaker to make a decision really, and we really can prevent many deaths and disability from cardiovascular disease by doing primary prevention. ملک
دکتر نداره
نه ملک کوچک بدون
ملک
Any other questions from the participants, or is that it?
tums.ac.ir.
یکیش برای اینه ولیش برای کل
دانشگاهمونه.
یکیش هم برای کل
میخواید بگید که ایمیل شروع شده
I have shared my email.
ملک امش کوچکه چرا بزرگ نمیشه
I have shared my email. It is malik@tums.ac.ir. I would be pleased to be in contact with any of your colleagues.
Thank you so much, Professor Reza, for the insightful presentation. I will share the presentation slides with the participants as well. I would like to invite Dr. Muhammad Ali Messer, who's a consultant here at Comstech, for the concluding remarks of the webinar. Over to you, sir.
Thank you. Well, ladies and gentlemen, I hope you have all enjoyed and personally benefited from this very important talk by Professor Dr. Reza Malekzadeh. Dr. Malekzadeh, with his absolutely fascinating credentials, is the right person to speak about such an important invention like Polypill. I just only a short while ago, before the talk started, I saw this estimates by WebMD show 2 to 4 million premature deaths, heart attacks, and strokes could be avoided annually if the polypill, half of the population of the world takes polypill. Nevertheless, with this short introduction about the polypill that I have learned about, I thank you all for joining this important talk, for which Comstech has taken up the responsibility of making such talks available to the OIC population from time to time. And I thank Dr. Malekzadeh for finding time to make the people who attended this talk so knowledgeable about polypills. Thank you so much. Grateful.
Thank you. Thank you very much. And it was a pleasure being with you and the team. And I hope that we can hopefully do more collaboration. I think something that is very necessary between our Islamic country is just the scientists get together to improve the health of the old people. And this is what I am very interested and would be pleased to join any team who is very interested to collaborate.
Thank you so much, Professor Reza, and thank you to all the participants that participated in this webinar. We have more webinars and workshops coming up in the future. So for that, please visit our website, comstech.org, and register accordingly. As for the participants, final reminder, those who have attended this webinar, please leave your attendance in the email to me, hasib.ahmed@comstech.org, so we can issue you your e-certificates accordingly. Thank you once again to everyone, and that would be it for today. Thank you.